Distinguished participants of this webinar, I want to take this opportunity to thank the Africa Health Collaborative for giving me the opportunity to share with you my thoughts on how higher institutions of public health education can really support the reimagining of primary health care in the era of resource-limited settings. These ideas that I present have been put together from several pieces of evidence, but please feel free to jump in with also solutions that you suggest, because this discussion also goes to support the improvement of higher education and to improve public health in at least the global south and also in the world. So in this presentation, I'll have a brief introduction. We'll go through the contextual issues, a definition of primary health care, the milestones of primary health care. We shall discuss why this subject is important and the actions that public health training schools can also take to indeed cause more impactful influence. And then we shall have a discussion. So as you might, all of you know, or those who are in this webinar today, primary health care in the global health space is actually under pressure due to several financial constraints, demographic changes in various parts of the world. You are able to tell that the youth maybe are now about 60% of the world's population, but then they're also aging populations, and therefore those are influencing or the demand for healthcare. I also have a changing burden of disease, a mixture of infectious and non-infectious diseases, outbreaks that are happening very frequently in different parts of the world, complicated or compounded by climate change and its impacts on health, and of course, reduced development aid. Some people have called this a poly crisis, which we are facing. We've also seen primary health care evolve from different stages. Most importantly, the Alma Ata Declaration, the Astana declarations that are recently talking about the need to reshape primary health care to make it people-centered and to address the needs of different populations. We've also seen that traditional donors who have been supporting primary health care in the global south mainly are scaling back. There's need for local innovation, and there's need to have self-reliance as critical pillars that support primary health care. You'll also recall that now the health workforce that is in this system is overburdened, but many of them do not have the skills to deal with this polycrisis. We have health workers perhaps trained to be medical, yet health interventions now also need you to tackle what we call the social determinants of health, to provide leadership, provide innovative financing, planning, applying technology. But the current health workers we have do not have that strength to really deal with this crisis in an integrated manner. We also have public health students trained, but they do not work from where they do not work in the place or practice during training in places where they are going to work finally. For instance, you could have students who get admitted in universities in Toronto, but then will have to do work in Nigeria. That knowledge experience gap is a bit of a challenge, and therefore it's an issue that we need to solve as we reimagine the role of public health education institutions. You'll also recall that we have just come out of a global pandemic, COVID, which really exposed and weakened health systems. And before we recover from that, there have been other outbreaks, there have been challenges in financing, And that's one calls for us trying to make sure that we rebuild these health systems, and higher institutions of public health education have a role in that. We also know that there's a climate crisis. It's a very hot topic now. Global warming is very alive, and we're already seeing the impacts. There are many conflicts around the world, especially in the global south, and they influence how resources are committed, how healthcare can be delivered, and also the outcomes of health. We also have the issue of urbanization. Many populations are moving from rural areas to urban areas. That affects the way they live, the food they eat, and therefore the health that they will attain or maintain while they're in these particular areas. And this also is great pressure on primary healthcare systems, and this needs to be addressed as we imagine what systems can attend to these challenges. So I want to discuss and argue that public health education institutions have a big role to train health workers who will be able to uh, challenge these or meet and solve these problems that we are seeing. They also are uniquely positioned to champion innovation, to influence policy, and to deliver sustainable health systems. So primary health care has been defined over time, and I'll share that very shortly. But right now, primary health care is a whole society approach to health that focuses on providing accessible, affordable, and comprehensive health services to individuals and communities, aiming to improve their health and well-being at all levels. It should emphasize the importance of engaging communities and empowering individuals to make their own health decisions, working across different sectors to address wider determinants of health and ensuring the highest attainable standard of health for all. Going with those definitions, I'd like to share what is now mapped as the actors in health. So we have on the left picture, you have at the center, we have the community health, which is really primary health care as we know it, really reaching households. And we have a formal sector, which includes the health workforce, medical products and supplies, medical infrastructure, health financing, the health management information systems, service delivery, leadership, and governance, the health system building blocks as we know them. This has a direct impact on households and health generally, but this system alone, or the formal health sector, cannot be sufficient because it needs other collaborations. Collaborations, as we go clockwise, can be also with the other societal partners, the informal health providers, traditional birth attendants, traditional healers, bone setters. We now have churches and people practicing alternative medicine. These, even if it were not a formal collaboration, also have an influence on the decisions that are made by individuals, by communities, really to address their health. So we must have these collaborating with the other sectors. We also have the non-traditional health sectors, but which contribute a lot. For example, education contributes to awareness. The education process is a social vaccine against many things, including problems we see like teenage pregnancy. But they also provide health literacy because there is a lot of health programs that go on in the education system. We have agriculture, which contributes to nutrition, and if the agriculture sector delivers, then we are supposed to achieve a good well-being. There's the environment, which is particularly critical these days, of course, for where people live, the water people drink, um, as well as now the influence of climate change that we see. So it's a very important sector. There is a sector of security. As I discussed earlier, during conflict settings, it's difficult to provide healthcare. So we need security. An unpeaceful environment causes migration. Of course, health workers are sometimes targeted and they affected most of the time. So it's a sector that we need to engage with, make sure that there's peace and security to enable healthcare to be delivered. Water hygiene and sanitation, also very critical, as I mentioned earlier. There's a social welfare system. There's a whole road and transport system that influences how the supply chain really will perform. Of course, the information sector, women affairs, gender, all these are cross-cutting areas that need to be engaged as we deliver primary health care. We also have the societal partners, and non-government organizations, civil society, community organizations, philanthropists, the private sector, and so on. You will notice that the academia is not mentioned anywhere, but the academia produces students and graduates that influence all these sectors. So if you have someone only medical and knows how to work in the medical sector, but does not know how to integrate or to view the influence of these other sectors on healthcare, then the healthcare delivery will not be successful. On the right, I've tried to share an example of a health system, and I'm using the example of Uganda to show the structure of the health system and the population that takes care of. I pray that this presentation is shared with you, the participants, so that you are able to see. But very quickly, the Uganda health sector is divided into two main portions or actors. We have the public sector, which includes all government health facilities and delivery channels of the armed forces and local governments. Then we have also national referral hospitals, regional referral hospitals, then the district health system as you go all down until you reach level 1, where we have community health workers who in Uganda are called GVHTs. We have the private sector as well, and this involves private for-profit providers. We have private not-for-profit providers, which are usually faith-based, and we also have really traditional and complementary service providers. Now, a graduate from a higher institution of public health education should understand that there's a structure, there are collaborators, and medical schools, therefore, or public health education institutions should have trainings and that make sure that the product they deliver is able to work in these systems and to know the support systems around them and what is influencing the demand for health services and therefore how they should respond. So there is primary healthcare has actually evolved, and it was first discussed as primary healthcare, defining it as the first level of care is somewhere in 1920 by the Dawson report, and has evolved over time. I'll not go through all the stages, but has evolved over time. And one of the key milestones was the Alma Ata Declaration of 1978. You can read more about that. And lately, as you'll see, almost every now 5 or so years, there's a discussion on how primary healthcare should evolve, and it has an agenda and showing you how important primary healthcare has become and how we need to focus on that. In fact, there are many discussions going on around the world, which point the fact that now that we have scarce resources, but a huge demand on health, We can no longer rely on the clinic or hospital-based care. We need to emphasize preventive care so that we prevent diseases from developing in the first place, but also we make sure that they're taken care of through early detection in order to prevent the complication and consequences of late disease management. Now, in this current situation where resources have reduced, everybody is trying to determine who is most affected and therefore who should we target. Of course, from the data that is available now, we have seen, for example, the impact of withdrawal of USA bilateral health assistance to be affecting mainly countries in the global south. And interestingly, if you look at the top 10, starting from the left, you'll see that a country like Afghanistan, which has been conflict-ridden, Somalia, South Sudan, Malawi, and Haiti, Uganda are very close, and they've lost quite a significant chunk of money that was subsidizing their health programs. And therefore, the priority to reimagine healthcare, primary healthcare, should really target these countries as you see them. And within the countries, of course, the most affected population are those who are not able to meet their out-of-pocket contribution to this to buy healthcare. So it's going to be very important that even within countries, we are able to really innovate to make sure that we have healthcare reaching the poorest of the poor, ensuring that there is equity. So getting to the gist of the matter, what should be the contribution of these public health training institutions? I think what is needed here in the short term is really to stabilize the ship. The ship of primary health care has been hit by waves of shortages, waves of uncertainty, and we are going to see it really impacted. So everybody should work towards re-stabilizing the ship, ensuring that we reduce mortality. And public health training institutions can quickly do assessments, identify gaps, and help countries and communities prioritize what should be the critical these critical challenges and burdens, and also ensure that we do not see an unprecedented surge of mortality like we saw when we saw in COVID. And COVID was one single outbreak that affected many parts of the health system. And the withdrawal of development aid and funding strategies will also cause the same, and the impact will be on mortality. So there should be quick steps to really address the critical and emergency conditions so that we don't have mortality. We should also assess the impact of these funding strategies on the components of primary health care. Is it in the workforce? Is it in the supply chain? Is it in the information systems? Is it in the leadership and governance? All these should be, there should be a quick assessment so that the evidence is used to reshape primary health care. Institutions of public health education can also rapidly build capacity of health workers. We take on some tasks that were perhaps not previously taking on. For example, task shifting. I think there should be a conversation on task shifting where roles may be played by physicians can be transitioned to maybe midwives and nurses. And what nurses and midwives were able to do should be safely transitioned maybe to community health workers. We should also think about promoting things like self-care, because many solutions now can go through self-care. People can now take their own blood pressures. People can now administer to themselves some family planning methods. So this is something that higher public health training institutions can actually influence so that it can help the continuity of services in communities. Of course, the institutions can also help health systems to continue function as they rebuild and reshape the way they work. In the long term, medium and long term, there are some areas I came up with that training institutions should work on. One, they should really reshape the way they teach and deliver courses so that they create fit for purpose health workforce by transforming the education to that one which is impact driven. And this, I propose the following actions. One, academic programs should move from being siloed, theoretical, to being interdisciplinary, practical, focusing on problem solving in their curricula. The reason I am suggesting the interdisciplinary training is that, as we saw earlier in the structure or that influences the health of communities, there are many areas that really are not medical, are not even public health. Education, for example, in a lower level, in a primary school, in a secondary school, looks at many things, but you could start nutrition training there. So a health worker trained for this age should be able to use the education system to prevent things like malnutrition, diseases, water hygiene and sanitation by using the education sector. And that's why you need the interdisciplinary training. There's been a consistent argument in many countries where finance practitioners in the country, those who deal with budgets and they allocate resources, say that no, health is just a consumptive sector and does not produce anything. But and so they say no, let's invest in education, invest in agriculture at the expense of health. But if the two actors are learning together in a public health training institution, then this will help them to understand why investment in health is critical. I also propose that there should be core learning that integrates systems thinking, climate change, using digital health to ensure resilience, tackling social determinants of health, and also looking at mental health and well-being. Mental health is one thing that is one other challenge that is emerging in the world, and not just for people who expose themselves to challenges to mental health, but even the health workforce itself, because of the burden of disease, the strain they go through, they really need mental well-being. So this is also something that public health training institutions can actually focus on to make sure that they have health workers who are able to maintain their own mental well-being in order to serve others. Then we should also, the school should also look at competence-based and interprofessional educational models that really develop skills, not only knowledge, and produce networks among students of different professions, so that when they enter into practice, they are able to leverage on the resources or networks they have already built while they undergo training. Also, another area that needs to be addressed is a training institution deepening their engagement in communities and government, and to work through partnerships so that the needs in the health, in primary healthcare are properly understood by these medical schools. As I showed you, primary healthcare has evolved over time, and the challenges that the communities face are also evolving, becoming more complex and intertwined. So we need to make sure that the training is relevant to meet these needs, and can only be done by training institutions forming partnerships, working very closely with ministries, relevant ministries, departments, agencies, local governments, civil society, to co-create research agendas, teaching agendas so that they can generate relevant evidence, but also generate relevant content to train the health worker or public health practitioner who will be relevant in these challenging times. There is also the critical area of ensuring adaptive leadership and innovation. Leadership is a very, very big input into primary health care and public health as a whole. And this is a kind of leadership that needs to shape the mindset so that when a leader is in practice, then they're able to recognize that there are evolving needs. The needs are complex, and therefore you need to have the change in mindset. So institutions should emphasize that the leaders they train are focusing on implementation science. They are able to carry out strategic planning, to use data for decision making, to ensure that they create resilience mechanism of the health system and delivering care in limited resources. We also need, training institutions also need to leverage technology and lifelong learning. I don't know whether there is any institution that really maintains contacts with their alumni or graduates, and maybe 10 years down the road, ask them, how is the practice going and how can we be of help? And many training institutions are focusing on graduating a lot, and then the next cohort and the next cohort, and they don't have that linkage. So you can leverage the technology to make sure that you're able to follow up, provide CPD beyond the time when the student is with you in the institution. Also, institutions of learning can also become catalysts for change. Ultimately, public health institutions must also position themselves as both educators and agents of social transformation. They need to align education, research, and service delivery with context-specific needs, focus on equity and also help to build inclusive and resilient health systems. Institutions should also look at, therefore, lead reviewing curricula of countries in the training that goes on or in the education that goes on. Because we know higher institutions of public health education receive students that have been educated from other systems. They've gone through what we call primary school or the formative education. They've gone to secondary education, and therefore you receive products that have already been shaped in certain ways. So I want to argue that it's the role of higher public health institutions to really influence the whole school or learning curriculum of the workforce that's being produced in a country. So that by the time you get a student, you get a student who already has problem-solving skills, who can innovate and can transfer these skills into public health as they train with you. Then, of course, the curricula must continue increasingly utilize digital tools to also deliver health while utilizing such tools. Should focus on the climate and climate resilience. It should also focus in ensuring that the graduate is able to foster cross-sector collaboration. These institutions are also very important in operational research to help evaluate what works in low resource settings and developing such models that will work when a student will use, or a graduate will use while working now in the public health sector to deliver primary health care. Of course, this cannot be only achieved by the public health training institutions alone, but they need to work with the Governments, they need to work with the NGOs and communities themselves to come up with such impactful and efficient models. Higher institutions can also strengthen local governance by providing technical support for decentralized planning, budgeting, accountability in primary healthcare, by offering leadership trainings and mentorship. This is also a very critical role that institutions can play. Also, of course, I already discussed issues on digital health. I just want to add on the integration of AI. I don't think many public health institutions have adopted AI in the way they work, but where we are going, you need to have real-time data analytics and I beg your pardon? I beg your pardon? Okay, so let's proceed. I'm about to conclude. We need to integrate AI, mHealth, telemedicine, really to use in order to be efficient in these times of poor resource settings. Of course, higher institutions can also be hubs of innovation, supporting startups, their deployment and scaling up, and also help these startups not to die. Many startups die when they are piloting because they do not have sufficient support. Training institutions can also support sustainable financing models through research and through enabling governments to take on such models and influencing policies so that they ensure that the funding or the limited resources that are available actually are used efficiently to support or to buy the health that it should be buying. They can also catalyze technology transfer from the north to the south through collaborations, inter-university collaborations. Then you can get some technologies that you can bring from the high-income countries, the low-income countries. I think it's a role that universities can play. Also, you can these institutions can facilitate research into alternative therapies and make sure that they are safe for use. And I'd like to highlight the case of a therapy called Covidex. If you have some time, you read about it. That was generated from herbs to manage COVID when Uganda had challenges in accessing vaccines. There was a big long gap and nobody knew how to treat COVID well. And this was a very big innovation and is now on the market. There are a couple of case studies that we know, and there are quite several, on how higher institutions of learning have helped do public health reforms. I cite two here, but there are very many such case studies. The first one is the primary health care under one roof, which is in Nigeria. And this was championed by Nigeria University that supported, University of Nigeria rather, that supported its development and evaluation. And this reform really created state primary health care development boards as an innovation, which enhanced accountability and quality of service delivery. There is a good evaluation report, which you can read at your own time. The other example I'd like to share is the contribution of Addis Ababa University that supported the development of the health extension program, which is very popular. And now I think it's even cited as one of the exemplar programs by the World Bank. You can read more about it once I share these references. So I conclude by saying that these higher institutions of public health education are really uniquely positioned to make a greater contribution in the reshaping of primary health care systems in the world. And they are getting even more relevant in the face of declining aid and they need to develop more local appropriate, cost-effective, resilient health systems. But for this to happen, even the institutions themselves must need to transform and change their mind shift, to have a mind shift in the way they do training. So from really a knowledge producer to really a system transformer entity. In this era, of course, these institutions should reinvent themselves and become more agile, more community-centered, more innovation-driven. They should play the role of a catalyst for the general public health leaders and capable of producing effective primary health systems grounded in equity. So this is I share a bit of references which you can use to read more about this subject.